That's excellent. I can see more questions flooding in for you here, so we might save some of those for the Q&A at the end of the session, hopefully. So I'll move on just now, if that's okay, Doug. But thanks very much for that. And I'd like to move to Ken Walker and Stella Vig, who are going to talk about surgical boot camps.
Well, thanks very much for that, Doug, and thanks, Steve. It's actually a great pleasure to talk about these courses, which are more for the starting end of surgical training, because certainly the ones we've been running in Inverness over the last 9 years, we've really enjoyed hosting them. Look, I guess the title boot camp is a little bit tongue-in-cheek, not everybody's cup of tea perhaps, we might come back to that. But what they are is holistic induction courses for new start core surgical trainees. And new surgical trainees, I think, are very hungry. They're at a point of transition and they're hungry to acquire skills and to cope and be safe and to fit in and to be a surgeon and to know the secrets of surgery. And that's a great opportunity, not only for accelerated skills acquisition, but for us to have a good think about what exactly are the essentials for a flying start. And also to think about setting some of the norms and expectations for a community of practice. You know, there's a lot of literature around community of practice, and the literature says that if we don't set those norms and expectations, then they tend to be set by myth and hearsay, and some of those myths may include dangerous old stereotypes like, you know, for a surgeon to call for help is a sign of weakness and that sort of thing. So with all those things in mind, the team in Inverness fashioned this 4-day program, and we tried to include 10 evidence-based principles for success in simulation-based education, including the ladder principle of Barry Essenberg's, meaning that that trainees have the opportunity to practice sets of skills in simulations of increasing complexity with a lot of immediate feedback and debrief. And so another way of depicting our course, the contents would be like this, which I showed you in the last webinar, these two progressions or ladders in technical and non-technical skills. And the ratio in our course is about 50-50, or I should say 40-40, because there's 20% of other things. If we think about the technical skills, we have the advantage in the UK that our core trainees have already done a basic surgical skills course. And so they can go straight into these intermediate tasks, and we give them plenty of time for repetition. I mean, two-hour workshops in each of these wet labs, bowel anastomosis, skin flaps, vascular anastomosis, so that they can get to feel the benefit of repetition. And Viv's going to talk later a little bit about the theory there and about the laparoscopy component as well. So I'll tell you more about the non-technical skills side of things. And Steve, I was thinking again about why we put this up front, and it wasn't just the evidence and the science you gave us about non-technical skills being so important for patient safety, but it was also, there was a certain resonance with things we valued and wanted to value more, you know, flattening of hierarchy, encouraging speaking up, all these sorts of things. So after a classroom session, trainees have the opportunity to do a tabletop prioritization exercise and some phone calls with group feedback and debrief, and lots of lessons come from that. And then to move into a complex task, which for our first year core surgical trainees is a ward round rather than an OR. We do have an OR-based simulation later in the second year. But the ward round, in the ward round, they're asked to lead a ward round on 3 patients who are in fact volunteer patients, lead a team who are in fact confederates, and gather information, make decisions, communicate well, and so on, and safely, amidst a lot of background hubbub and interruptions and so on. And like Doug said, all of the learning's really in the debrief, and we have some studies around that. And this simulation taught us a lot, just running it. It taught us quite a lot about when to use complexity and when not. So you can see this is a complex simulation, and we learned that if you're going to be complex, you've really got to go all the way to get it right. If you get it mostly right, but a few key things wrong, you know, right down to where the venflons are and the drug cardexes and so on, then it can start to feel very uncanny, the so-called uncanny valley, and you've lost your psychological fidelity, and you would have been better to do something more simple, like all the other simulations in our course. So we learned a lot about that. And fidelity, by the way, is a much misused term, which we could talk about in discussion if you like. Then after that, complex communication skills challenges with an actor who's just brilliant. And that's aligned with a group of sessions I've called Community of Practice. There's one called How to Get the Most from Your Trainer. There's one on resilience in surgery, and there's another which uses storytelling to illustrate the highs and lows of surgery. For example, we might talk about complications and what's important to patients and their families, but also the impact on ourselves and our teams. And there are sessions around a very dynamic journal club and some operation notes writing. So there's a lot in the boot camp, and the feedback, I'm pleased to say, has been warm, the immediate feedback, and gratifying to see that the technical and the non-technical are equally valued. Now that, of course, as Doug was saying, about outcome measures being difficult, this is not level 3, level 4 outcome measures. We may get some of that from the study that's going on of the Scottish IST simulation pilot at the moment, because this course sits as part of a wider strategy now. But we don't have that to date. What we do have, though, is an interesting qualitative study by Professor Jen Cleland, who in one of our earlier camps, she described the boot camp through 2 theoretical lenses. I know how you surgeons love your educational theory. Maybe not, maybe yes. Well, she described it through the lens of capital, the different kinds of capital that trainees gain, and also activity theory, understanding that the whole activity system of the course actually matters, including the social time and so on. So that's a good read if you want a more in-depth read. And I'll finish up by saying that I think these are the lessons we learned from running this course. I think I've mentioned all of these ones. Maybe just pick out the last 2. We've changed how we do debrief since the start. I think at the start we were quite wedded to, like a lot of surgeons, to Pendleton's rules, you know, something good, something could be better, something good, as is cruelly depicted in this cartoon. And actually we found that's quite clunky. When somebody comes out of a complex simulation, they want to get things off their chest, often the most challenging things first. We've switched to a different model now, which was given to us by our colleagues in the Scottish Scottish Centre for Simulation and Clinical Human Factors. And in fact, we've invited them to the last webinar in the series in 4 weeks' time. And another thing we learned is that there are the stated learning outcomes, and then there are all these seemingly incidental or surprise learning outcomes. And we've learned to actually treasure those and smuggle them in a way, because some of them are as much about attitude and approach as they are about the skills. So I'm going to hand over to Stella, who has an equivalent course in London, for her experience, except to say before I go that if you would like more detail, we do have a paper out recently in I think a reputable journal edited by Doug. And there's a website, and we're happy to share experience with other units. We have with units around the UK and abroad.